right, we're going live and
All right, I'll go ahead and start recording.
okay. All right. And George, if you just want to make me co-host as a backup.
Sure. All right.
Okay. And we do always
Good.
make the captioner a co-host just as a safeguard. I mean, I guess if she gets dropped and comes back on.
Okay.
Yeah, I don't know.
Yeah.
Okay, good.
Perfect. All right. Thank you, everybody. Did we check to make sure the subtitles are showing up on YouTube?
Hey, let me check. Dawn, could you just type? Oh, you're testing. Okay. Yeah. Yes, that's a go.
Great. All right. We're all set. Thank you. Good morning, Rick, or afternoon. We'll get started in just a minute. Just to remind everybody that we are live streaming on YouTube, and this meeting is being recorded.
Hey, George, you're muted.
Thank you, Rick.
Yes.
So good afternoon, everybody. I will do my quick intro before turning it over to Rick Jackson, our chair. This is the meeting of the training work group of the Alzheimer's Disease and Related Disorders Commission. I'm George Worthington, the Dementia Services Coordinator with the Department for Aging and Rehabilitative Services, or DARS, and I will go over my housekeeping. So, due to the active state of emergency, this is an electronic meeting pursuant to Item 4-0.01 of the 2020 Appropriation Act. Meeting notice has been provided. The meeting is being recorded and minutes are being taken. All votes will be conducted by a roll call of voting members. Meeting materials are posted under the Alzheimer's Disease and Related Disorders Commission's quarterly meeting tab at the eda.virginia.gov/boardsandcouncils.htm site. Members of the public are able to live stream this meeting via the DARS YouTube page. Please be advised that if the live stream is interrupted, we will need to pause the meeting until it's restored. Public comment will be accepted by email or phone to my attention. Public comments that were received by yesterday, February 2nd, 2021 will be read, or if lengthy, summarized during the meeting when we reach that agenda item. If I have your okay, I'm going to skip the Zoom function since I figure everybody's, yeah, okay, I see some thumbs up. I would ask that if you have your video enabled, please be aware that the system may capture your image and video in the public streaming and recording. And please only use the chat feature. Please only use the chat feature if you have a technical issue or other issue not related to the business of this meeting. Chat comments are not captured in the live stream or the recording, and so are not available to members of the public. You can also use reactions to do a thumbs up for agreement or a clap to raise your hand to speak, although this feature may not be used in place of a verbal vote in a roll call vote. If you'd like to view the real-time captioning of today's meeting, please click on the CC button on the menu bar at the bottom and select Show Subtitles. Zoom participants will be able to turn on their closed captioning. The YouTube streaming will automatically include the captioning. And for all votes, we will do a roll call, and you'll be asked to indicate your support with an aye or a yes, an opposition with a nay or a no, or you can abstain. Lastly, I'd like to thank the DARS video teleconferencing team and the DARS communication team for making this electronic meeting possible. I'll do a quick roll call of members to confirm attendance in no particular order. Rick Jackson.
Here.
Denise Butler.
Here.
Vicki Armstrong. I see you there, but you may be muted. Chesley Williams.
Here.
Thank you. Kim Kuttner.
Present.
And Karen Garner.
Here.
Thank you. Okay, Rick, we have, so Laura Bowser sends her regrets. She's unable to be here today, but we do have a quorum, so I'll turn it over to you now, Rick. And let me just post the agenda.
Very good. Thank you all for taking time out of your day and joining us. We really appreciate your assistance and your help. By now, you have received a number of items from George, which we'll obviously be talking about today. And the first item is the agenda itself. And so we need to approve the agenda. Could I get a motion to accept the agenda?
This is Kim, and I move that the agenda be approved, accepted.
Could I get a second?
Second.
So all in favor of accepting the agenda for today as submitted to us by George, please indicate by saying aye.
Sorry, Rick, I'll have to do a
Aye.
roll call.
Oh, go ahead.
Rick Jackson.
Aye.
Denise Butler.
Aye.
Vicki Armstrong.
Vicki, you may be muted.
Yeah.
Can you hear me now?
Yes.
Yes.
Okay. Aye.
Thank you. Chesley Williams.
Aye.
Kim Kuttner.
Aye.
And Karen Garner.
Aye.
Great. Thank you,
Thank you.
George. It looks like we have a unanimous vote to accept the agenda. And the next item on the agenda would be the minutes. One of the things you received from George were the minutes from the last meeting, which was held November 18. There are several pages, as you can see now. Hopefully you have had an opportunity to review them. This would be a chance for you to edit or make comments or corrections to them. Anybody? Any? Hopefully you all received them as well. You have them in front of you, not just on the screen. So Hearing no discussion or edits, then I guess we should take a motion to approve the minutes.
You can adopt them as presented, Rick. We don't need to do a vote or a motion.
All right, so the roll call again, or I can do it.
No, you can unilaterally adopt them.
Okay, so everyone in favor of accepting these minutes would please say aye. Any opposed? Hearing none, we will adopt the minutes as presented. This is the opportunity for public comment.
Yep, no public comment was received, Rick.
Very good. And we have no one apparently live on the call from the public.
No.
Okay.
No.
So moving on from that item, then the next item on the agenda is, of course, the view of all the wonderful handouts you've received from George. One of them is a brochure, which we discussed at great length at the last meeting, and the other one is the toolkit. So why don't we start with taking a look at the brochure to see what comments, edits we may have for that. It's in front of you now.
Yeah, so if I may, Rick, I'll just walk through the
Yes, sir.
changes. So I didn't make a lot of material change to the brochure since we last spoke. I have tried to tidy it up and format it a little bit better. We're still working on that logo for the Dementia Capable Virginia initiative. So there's nothing there, just a placeholder. But so this side of the brochure didn't change. We have the outline of the Virginia State Plan, a quick intro to the Dementia Capable Virginia initiative, and then obviously our contact details. So the inside of the brochure, I kept the same three columns, so the training, the resources, and the referrals, but I tidied it up a bit to make it a little bit easier to read, and added in a few websites and group things a bit better, I think. So under the training, we have the Learn to Use Screening Tools section, which directs people to the DF America, dementiafriendlyamerica.org website, where those training videos can be found. And then it details what those videos are related to the various screenings, so the MiniCog, the SLUMS, and the MoCA, which we discussed at the last meeting. And I've just added in that that certification is required and where they can find that for the MoCA. So practitioners who want to use the MoCA have to complete a training and pay $125 for a 2-year license or 2-year certification for that. Then we have and so those are all reproduced from, so I had a discussion with Dementia Friendly America just to confirm how to acknowledge them. We do not need to have this here because we're just linking to their site. However, in the toolkit, which we'll get to next, we do have to acknowledge that we're reproducing those items from Dementia Friendly America. So then we have any questions about that section or comments or thoughts? Okay. So the microlearning for primary care providers, that's the microlearning developed by Riverside SEAL, Center for Excellence in Aging and Lifelong Health, and the link to where they can find that, which is they're currently posted on All's Possible. We have discussed developing a Dementia Capable Virginia website where these would be housed, but until then, we're going to continue to rely on allspossible.org for that. And under the resources section, so these are the resources that are actually included in that toolkit, which I sent you, which we'll get to next. So the clinical provider practice tool after a diagnosis, the care coordination practice tool, and then there are also some videos on how to use those, particularly around care coordination. And then we have, again, we don't need to put that reproduced there. It's that I'll strike. Then the box highlighting why it's important to detect cognitive changes early. And then the last column is the referrals section. So we want to make sure that primary care providers are connecting patients with appropriate services and supports. So actually, I'll just digress for a second. I was on a webinar earlier this week with, it was discussing dementia training for the workforce, and it was a pretty high-level group of folks. They had the developer of Project Echo from New Mexico, Joe Gulgler from the University of Minnesota, and another of his colleagues, and the health, the person who runs the health system for the Cherokee Nation in North Carolina. And one of the things that they said, which was interesting, was that it wasn't so much the screening and the diagnosis that primary care providers were having, were not doing well. It was more the referrals. So, you know, I hear both sides of that. So some folks do have difficulty getting a diagnosis, particularly earlier on in the disease process. But there seemed to be a pretty strong consensus from those folks that it was the referrals where the primary care sector was really falling down a bit. And so we want to make sure that we're providing really great tools for them to use and key referrals. So the Community Organization Practice Tool is one of those Dementia Friendly America products, actually Act on Alzheimer's products. The Dementia Roadmap is what we're working on in the Coordinated Care Workgroup. And then the three key referrals would be to the Alzheimer's Association, to the local area agency on aging. And so for that one, we do need to have, so I'll put in the number for the DARS information, senior information, where they can get details on their local area agency on aging. Otherwise, we'll have to print or develop 25 separate versions of the brochure, which might be difficult to keep straight. And then virginianavigator.org. So I added in the bullet points under each of these to kind of highlight what those were focusing on. Thanks. Karen's just put a note in the chat. Can we put the Alzheimer's Association website? Absolutely. I will add that in. So alz.org. Any other comments about this, or thoughts, or ways to improve it and make it more user-friendly?
Thanks, George. I think just where you have space, because I know you have to make sure you don't have it too far up and too far down. I know there's a spacing thing, but like just for the Alzheimer's Association, for an example, I don't know if you could put 24/7 helpline, like the 24/7, like in front of helpline, if there would be enough room. And then local area agency on aging, like maybe space that out a little better instead of just having AAA like underneath it like that, just so it looks better, I guess. Just a comment.
Yeah. No, I agree.
Kim, just like ALZ, I would add the national AAA.
Yes.
Website. So then they could put in their zip code and get. Their local.
Is that right? I did not know they had that.
Well, I hope. I mean, I'd have to do it and make sure, but just a little placeholder to see if there's a website for that. Otherwise, you have to Google each
Yeah.
location.
No, it seems to work. I put in my zip code and up
Okay.
pops my local area
Thanks for checking.
agency. So thank you, Kim. I didn't realize that was there. That's great. I know we have it listed on the DARS website as well, but it's our web address is very long, and so this would be much simpler. Karen, you're muted if you're.
Karen, you're muted.
Any other?
Oop.
I'm not talking to you guys. My son and my dog are doing something, and so I'm trying to make sure my dog doesn't tear up a room and listen to it at the same time. So sorry if I look like I'm trying to say something. I'm not.
Okay.
Hey, George, I just want to say, I think it's very well done. I think the challenge, obviously, in any of these efforts is to, in a very concise, easy to read document, put a significant amount of helpful information. And that's always the challenge. And I think it's done very, very well. And I think from a user's point of view, and I'll defer to Denise and Vicky and others, but I would think from a clinician's point of view to look at this, it would be very helpful.
George, I agree with Rick. I can tell you've put a lot of time in this, and having done brochures myself in the past, and not being a marketing or computer guru, I don't know about you, but I'm not. And so I can appreciate what it takes to do this. I do have a question right there on the community organization practice tool.
Yep.
Is there more information there? Like, is there a phone number or website or something, or what is that going to tell them by being right there?
Yeah, so that's a great question, Karen. I haven't quite worked that one out yet. So that it may be that we just provide that with this, because it's only I think it's, let's see, I'm going to shift briefly into this. It's not this one. So that's this document, which kind of goes through a flow chart of how to go about cognitive screening, and then also what supports and services to recommend. It's a 2-page, so 4 pages altogether. So yeah, we need to. So the idea, I guess, would be to have this on that dementia capable Virginia website, which we don't have yet. In the meantime, I can probably house these on the Dementia Services website, which I think I put on that brochure. Let's see. Yeah, so the VDA down here on the bottom left of that, under the Virginia Dementia State Plan, the vda.virginia.gov/dementia.htm. So that would, somewhere on this we'll put, that's where all the resources can be found, unless otherwise indicated. Does that kind of meet that?
Yeah,
You think that?
I was thinking under that column was going to be very specific, like phone numbers or places for them to go for resources. And yeah, although that is a type of resource, I just want to make sure it's sort of under that, you know, right there.
Yeah. No, good point. Thank you.
So,
The only
George,
other thing, sorry, yes?
I'm sorry. Under the dementia roadmap, will there be a link to that? I know it's not ready yet, or last time we talked, it wasn't ready, but there should be a link on how to get to that and under that
Yeah.
as well.
Yeah, so that'll be the same place. The other thing I kind of toyed, I hemmed and hawed a bit over was actually putting those the length of each video down there for the training videos. But then I thought, well, if they know that they're short, they're probably more likely to watch them. So I was going to go back and do the same for the microlearning for primary care, which I didn't have at the top of my, I didn't have easily defined. I'll have to go and get that by loading up each video. But
I do like having the minutes on there for that reason, because especially if they are caregiving, they want to know what they're getting into and how long it's going to take. But if you get to the point where just with editing and spacing, you could put something at the top, say all videos are between, it looks like 22 minutes, between 22 and 9 minutes, or something like you could just use online if it gets to that point.
Yeah.
I like having the time in there.
Thanks. And Vicky's just put in the chat that she likes that as well. Okay. Anything else? Otherwise, we might move on to the next. So the next steps for this would just be to give once we have the logo for Dementia Capable Virginia, we'll put this together as a final version, and I think with the content as is and with those edits that we've talked about today, are you happy for that to be shown to the full commission at the next meeting as a draft? Do we want to do a vote on that?
Sure. Is that a roll call vote, George?
It would be a roll call. Does
Okay.
someone want to make a motion?
I move that we accept it with the edits you have discussed to present to the commission at the next meeting.
I second it.
Thank you. All right. So roll call. Rick Jackson,
Yes.
Denise Butler,
Yes.
Vicki Armstrong,
Yes.
Leslie Williams,
Yes.
Kim Cutner,
Yes.
Aaron Garner.
Yes.
Great. All right. Well, thank you very much. So the other document that I sent you was something I put together since we last spoke, which I wanted to kind of bring this all together into one thing so that you'd be able to see these resources in one place. What I'm also going to do is a mock-up for a website that'll make it much clearer. So instead of having to scroll through a very long document, they should just be able to click on an image of the tool. So that would be like the front page of each tool to access the document, the PDF. But this could be something that they could access, everything in one go as well if they wanted to. So it would make this available as the toolkit and as each piece of it separately on the website. So I broke them down into pretty much the same the same buckets as on the brochure. So we have the cognitive screening tools and related training materials. So it's got all pretty much the same information that was on the brochure here. So where to find those videos, how long they are. And I did include the 88. I know we discussed this back and forth a bit, but this is, so I did a bit more research, and the Alzheimer's Association does support the 88 as an informant tool for screening. So my sense was that it would be better to include it than to leave it out. Any thoughts about that? And we can talk about it when we get to it. But within this the screening section, we have the clinical provider practice tool, which has that flow chart walking through what to do and screening and what happens if someone screens into the at a range of that you think there's some cognitive decline happening. Then how to do the workup, some basics on diagnosis, and then follow-up diagnostic visit, and a referral to the Alzheimer's Association. And we'd expect them to add those additional referrals to the AAA and to Virginia Navigator. So Vicky's just put in the chat, have we thought about the ability to link these Dementia Friendly America toolkits in the electronic medical record as a point of care tool? Yeah, Vicky, I did speak with Meredith Hanley, who runs the Dementia Friendly America initiative at N4A, and she said they had not done anything along those lines at this point, and that they don't have the bandwidth to pursue that currently. So that would be something that each health system would need to customize. So we could certainly encourage that they do, but obviously there's a cost involved in that. So that would need some internal advocacy, I guess, at each health system at this point. I'm not going to go through all of these tools in depth because you've seen them before. But then whatever is publicly available in terms of the screening tools, I put them in here so that they're to hand for the practitioner. So we have the mini-cog with instructions, the slums, and the 88 also with instructions and how to interpret it. So and some validation information about it as well. So those are the screening tools. Yes, that could be a project for later. getting this into the EMR. Any questions about the screening section? Does that look okay? I didn't put the MOCA
All
in
laid
because
out.
it was sort of. All right, thanks, Kim.
So, George, and this is just a comment, and we really can't do anything about it, but I just look at the page, dementia management, refer to specialist as needed. And I see neurology, geriatric psychiatry, and geriatrician, and I say to myself, good luck, because we all know how rare those individuals are, even in urban areas, let alone rural areas. And but I mean, that is right, that that's where you would refer, but it does make me stop and ask myself how difficult it will be for individuals who see that advice and try to use it when they discover they can't find them. But I don't think we can change it. That's correct.
Yeah, I mean, that's certainly, your point is certainly taken, and that's absolutely correct, that often you're not going to be able to find those specialists in your area. But there are areas of Virginia where people will find some of those, at
Yes.
least. So,
I think maybe another
I-
way to look at this is we're suggesting this is optimal. We're suggesting this is a model. We're saying
Yeah.
that we should advocate for citizens across the state to have greater access to memory disorder clinics and geriatricians and all these folks. And so for those reasons alone, I wouldn't change anything. I just would, we all could have an asterisk in the back of our head going, it's really difficult to find those folks, but we ought to do everything we can to increase access.
Yes, I agree. One thing with the memory disorders clinic, we do have that on all possible. We have a map of the clinics within Virginia as well as nearby states that Virginians could access. So we could certainly add a link to that here. Hang on. Oops. I think it's memory clinic, something like that, but we can put that in there.
You've got, if possible, I see in there. So that gives folks a clue that it may not be so easy.
I mean, you know, geriatric psychiatrists, there's probably fewer than 10 in the state, something like that. So,
Instead of geriatric psychiatrist, could we put, I mean, I'm just asking, can we put in neuropsychologist?
You know, Karen, we
Yeah.
can, but I would tell you they're just as difficult to find.
Well, I feel like, you know, we have to remember there are younger people that
Yeah, good point.
get dementia. And I never hear about a geriatric psychiatrist. All I ever hear about is a neuropsychologist for testing, no matter what age you are.
Yeah.
So yeah, so that would be for the full screening. I mean, for the full cognitive workup would be the neuropsychologist referral. And certainly that would fall under diagnostic uncertainty. So yeah, we can add another bullet point in. So we're free to change this as we like. We just need to, as long as we acknowledge DF America and or act on Alzheimer's. So.
But George, my other question would be, will it be obvious on the brochure to anyone who would pick it up and read it to know how to get to this?
Yes, well, yes. So the idea on the brochure would be that down here somewhere around the new logo, we'd have the Dementia Capable Virginia web page as the primary place to go to find all of these. Any other thoughts about the screening section? So the second section of the toolkit would be the practice tools. So again, these are the three things that are listed on the brochure: the clinical provider practice tool after a diagnosis, and the care coordination practice tool. I didn't put those in the same order, but again, these are basic things for the primary care provider to follow, as well as support for family caregivers. Again, some of these, so for example, it talks about care coordinator. Care coordinator may be available to you in your clinic or medical facility. So again, that's not going to be available to everybody in Virginia at this point. But in some places it will be. Thank you, Vicki. Vicki's needed to leave early. So, but again, it's some people may be able to access those through their Medicaid. So I'd say the numbers are higher than they were a few years ago for people that would be able to access care coordination. Specific dementia care coordination, you know, it's pretty limited at this point, but through advocacy, and we hope to achieve that in more parts of Virginia. And I think, you know, one aspect of this is that a primary care provider, if they start reading this and realize what's missing in their area, they might share that with other folks who can actually help make a difference there. Whether it's advocating directly to their local delegates or state senators, or through their professional groups. So I'll just flick through. Any thoughts about this? I mean, again, you've seen these before, we've talked about them. And then we'd also have a section to include that last section of the brochure, the referrals, and perhaps a longer section. So the Dementia Roadmap, for example, has quite a number of referrals that don't appear on this brochure. So things like referring to the ADRDC Center at NIA, the Alzheimer's disease. I can't remember what the acronym stands for. To the NIA itself for their Alzheimer's information. They have some really great caregiving guides available for free, things like that. There's materials available in multiple languages that people can download. So, so somewhere in that toolkit, we'd include all that information as well. But I just wanted to put something together to give you an idea of like the breadth of information that we are summarizing in that brochure.
Kim and Denise, in as much as you guys do a lot of care coordination, a lot of assessments, I would certainly be interested in your thoughts.
I think this is very helpful as a tool. With the links, user-friendly.
Yeah, I agree with Kim. I think it's very helpful, very user-friendly. It's clear. The bullet, you know, having things in bullet points gets people attention. And they can, you know, those links help them dig a little bit deeper for the resources. So yeah, it's a well thought out document.
So, and the best thing is that we didn't have to invent it all ourselves. So, what I'll do in the meantime, just so that we have something to go along with the brochure to present to the commission in March, is a some sort of mock-up of a web page that would be clearer than the toolkit itself and this document to highlight what we're including and what information this is providing to the practitioners. And I'll send that out with the post-meeting follow-up for any comments. But basically, what I would plan on doing would be just having a screenshot of the front page of each of those tools with a, that you can click on that picture and a very short description of it underneath. Click on the picture and you'd be able to download that document or access those videos. But I figure that'll be easier to take in than the toolkit itself here.
So they're hyperlinks, right, George? Where they could, if it's live.
Are you talking about a website mock-up?
Yes, if it's a website that they can click instead of.
Yeah, so that's the goal, is to have that Dementia Capable Virginia page where this would be housed. And so I'll try and put together some sort of preliminary design for that so that we can see how the sections would break up and how somebody approaching it from a practice would actually would interact with that page. That sound good? I think it'll be a little bit easier to take in than the toolkit itself.
I guess who would be using it from the practice? Is it the physician, the front office, the coach, social worker if they have it, and this primary care? It could be different at each office.
Yeah. Yeah, so I think we want, we don't need to be too prescriptive about that or directive. It's going to be who's going to be able to make the most use of it, and it could be multiple people within the practice or the clinic, but at the very least, the idea is to have someone who's interacting with those people with potential cognitive decline or with cognitive decline to know about this, to know it's there, and to know that they can access it as needed. And I think that's the point of the brochure.
Kim, I think in the cases of the large healthcare systems like Riverside and Centera, they're already going down a road of doing a better job of having their electronic medical records do clinical practice guidelines. So I think in that case, this will validate, inform, help them know that they're on the right track. I think if you go to a rural area or small independent practitioners that are not part of a large health system, they can rely solely on this. So I think it's going to depend on who they are, where they are, who they're affiliated with. But I think it's going to serve everyone really, really well.
So we're still looking at 3 pilot sites by September. I think we're on track. It's only February 3rd. Good.
So yes, we are looking at 3 pilot sites, and yes, that was the timeline that we had. It does need to tie in with the BOLD Act grant project, of course, because this is a deliverable under that. I'll just give you a quick update on that. The point person at Virginia Department of Health, the person who wrote the grant, has left, and that has kind of put a hold on things for the moment. They've been asked to hire a brain health coordinator by CDC, Centers for Disease Control and Prevention, who is the grantor, and that and it seems like until that person is hired and in place, that the project is more or less on hold. So I don't have a a clear work plan for that yet. And as I get more information on that, I will let you know. Hopefully things will pick up relatively quickly because we're nearly 6 months into that project, of the 6 months of a 3-year project. So, but in the meantime, we'll keep going on the original timeline that we had, which was that we would be hoping to roll this out in September. But you know, if we're ready to move it sooner, it's again the pieces from the different work groups need to come together, and we need to have that Dementia Capable Virginia webpage to help to set us up to move into that pilot stage. So I think that's all I had in terms of the documents, Rick. Rick, you're muted.
Thanks, George. Very, very impressive. Really appreciate all the hard work that went into this and everyone on the task force who has contributed to it. I think we can look forward to some wonderful things happening as a result of this work. You know, the next item on the agenda is actually outreach dissemination. We talked a bit about that at the last meeting. I was thinking about it this morning. And if you look at the training work group, we are very Riverside and Alzheimer's Association centric. And so, George, I was thinking about how we do outreach and dissemination. And I think actually we should have a robust discussion about that at the next commission meeting, because at the commission meeting, obviously we have representatives from across the state. We have representatives from other large health systems, UVA. And I think if we're going to be successful at this, first of all, we need their input, but secondly, we need their engagement and willingness to help us think about how we're going to do that.
Yep, no, that sounds like a good plan, Rick. And we did indeed talk a little bit about this at the last meeting, and so this outreach and dissemination, I see this as separate from the pilot project, because the pilot project we actually would need to evaluate, but we want to make these tools have been, I'm not sure what the word is, accepted, approved, or something for use generally. And so I think we want to make them available as soon as possible, even as that pilot project is going on. But the pilot project would provide us with some hard evidence of the utility of these tools, as well as hopefully a change in outcomes from using them. So so we can defer that discussion to the commission meeting if you like.
Thinking about, a committee of the commission to talk about this, and I was thinking about the AAAs and the Alzheimer's Association groups all over the state, and any number of large organizations, large health systems that need to know about this, need to have access to it, could help us talk about the value of it. But I see it as a pretty focused effort. that we ought to do with some real engagement from the commission.
This is Kim. I like to follow up with Rick's idea if there could be champions appointed by commission members for each of the health systems and to the smaller primary care provider, not related to healthcare systems, but or maybe we just start with the healthcare systems around Virginia. To have a champion to say, okay, we're going to speak with Michelle Wooten from Riverside, or to really tag someone and then the commission member follow up with that point person, or look for a champion and come back to you, George, a few weeks later with that contact information.
Yeah, Kim, that's kind of how we've always seen things at Riverside, is that any of these endeavors that have originated at the center needed a champion higher up the food chain than us that would endorse it and speak well of it and use their connections to tell us how to disseminate. So I'm with you. I think that's how we have to think about it.
Yeah, I think that sounds like a good plan.
So maybe that's how it could be presented at the commission meeting.
Hmm.
Their homework is to connect you with the right person in their organization.
Yeah. So, I mean, we will need some broader ideas as well, because we're not going to hit every system, but that would be a great foundation, I think. And also, we can of course push this out through the AAAs, and with VOLT grants through the local health departments, which I think will be key as well.
You know, with any luck, by the fall, health system focus, which has been totally absorbed by COVID for a year now, you know, hopefully we'll get a drop in the surge and we can go back to making this a higher priority, the way we want it to be, the way it has been previous to COVID.
Yeah, I think so. And even like dementia-friendly initiatives in various communities can help promote this as well, because one of the sectors that they're meant to be engaging with is healthcare and primary care. So,
you know, even the chambers, Cam, you're aware of this, you know, in some of the chambers of commerce in localities, they've established a health committee.
Yes.
There's one in Williamsburg, for example. And so to the extent that occurs in other localities, we can even go to businesses, to the chamber, and say, hey, we want your health committee of your chamber to be aware of this. So some really interesting opportunities.
Also with the free clinics and underserved populations.
Yep. All great suggestions. Thank you.
So George, that leads us to the next item about the next project. Apparently you've given that some thought, or you're just going to get ideas from us?
So I've given it a little bit of thought, and we did have some other proposed projects previously. So one would have been working on training for APS workers, and another was training, doing some training for the CCC Plus care coordinators around dementia. I think both of those are still, I'm not sure that the second one, the CCC Plus care coordinators, needs a full work group attention now, because it does seem to be on the radar there at DMAS, and we can, for example, or I can, for example, do a training on their monthly call. So that's something that, again, they've been very focused on COVID, of course. So as the situation changes, then we should be able to engage with them more. So, and on the APS front, the Adult Protective Service Workers, there was this time last year, I was aware of some work being done at VCU around this. I'm not sure where that project went. I didn't hear anything further about it, and our APS staff at DARS are not aware of that. So I'm guessing that would still be a potential project that we could do. I did a presentation at the beginning of last year, before everything changed, to the APS regional directors who decide what training their staff will have. So they have, for example, I think 4 annual in-person training sessions. That was their main training, and then they had certain other things that could be done on demand. And I had got on the agenda of one of those trainings prior to COVID, but of course that was canceled. So, so that's something that we can review. But those were, I guess, 2 ideas. So thinking about different sectors where we could effectively put out some sort of training, whether that's training that we actually deliver through DARS, or whether it's something that we work together with the Alzheimer's Association to do some training with. So Laura Bowser, who couldn't be with us today, she suggested some dementia training for dentists and optometrists in particular. Given the importance of both oral health and vision for folks with dementia, to help keep them healthy for oral health, and vision in terms of keeping them cognitively engaged with the world around them. So I've had a quick look. I just got her email about that this morning, and there are some practice guidelines for dentists and optometrists. Most of them come from the UK. I couldn't really find much here in the US. There was the Australian College of Dentistry has a full training course around dementia for their members, which we don't have access to. But that was one suggestion she had. So there's potential there for repackaging something and getting that out to an optometrist. But I'd be very keen to hear.
If we have the DARS dementia web page within DARS, maybe it could house, there's so many external trainings. I don't know if we need to reinvent or do another, bring in another. Just if I pull up, there's certified Alzheimer's caregiver. Insight has a bunch of trainings, Deepa Snow online, their champion courses, basic training. So maybe it's just and then even the practitioner or other, if we just point to a page that houses the Alzheimer's Association and all trainings going on, or if there's an upcoming webinar, and I know we send our information to you and then you can post it there with the rest, or Virginia Navigator, maybe they're already posting kind of on demand. Well, there's on demand, and then there are actual webinars that you just have to know about. It's like, how do you keep track of all these wonderful resources?
Yeah, no, that's a good point. So I'm just going to pull up the state plan so that we can actually use that to guide our conversation as well. Yes, so I'm not sure that I have the bandwidth to do that. we may be able, we do have a couple of interns at the moment, so I mean that could be something that an intern could work on as well. But there's certainly a lot happening in the training and sort of caregiving support space in Virginia. So it may be that on that Dementia Capable Virginia page we link to Virginia Navigator and the key organizations providing that training rather than listing each one. So for example, like the Dementia Friends, which is not really a training, but is more of an information session. Leading Age does post upcoming sessions of those. And we could link to that site as well. But yes, I take your point. We certainly don't need to house all this stuff on our website. So I've just pulled up the state plan goal 3, which is the training goal that we're tasked with. So they're looking at this, there's one. So A1B here, this integrating dementia-specific evidence-based training modules into existing trainings offered through these various departments and their local entities and contractors. So that's quite a big project. That might be something that we think about advocating for, or if we have something that we can give them or refer them to that's a prepackaged training opportunity, I think that would give us a foot in the door right away, rather than we need to work with you over a year to develop the training for your folks. So
George, if you look at A1B, my experience when I was at Hampton Newport News CSB was that often APS workers and emergency service workers got called simultaneously on the same case, and that there was not a good communication or a good collaborative relationship between those two departments, and they would often argue over who was the right person to be involved with it and whether dementia, whether or not we can serve them, because dementia is not a psychiatric. So what I'm getting at is, as we think about training for APS, I sure would love to include emergency service workers from the CSBs, if for no other reason to get them to talk to each other and think about other ways to collaborate and not point fingers at each other about who really should be involved and who should not.
Yeah, I fully agree with that. And one thing, getting the area agencies and the CSBs and the APS all to talk to each other. So that there is a budget item in the governor's budget under consideration that would set up a pilot for a mobile crisis response team under DVHDS that would be focused on dementia. So intervening at the emergency room stage, basically, to make sure that person was ended up in the place that was most suitable for them. So
where could we get more information on that? What is that called? The mobile crisis team?
Yeah, it's a budget amendment or a budget item in the current budget. I can send that out to you.
Thank you.
Is it all related to the crisis intervention teams now that the CSBs do and sometimes staff local ERs?
Rick, I'm not sure.
Yeah.
I'm not sure exactly how it's going to work. Just from reading it, it's a pilot. So I think the idea is that there would be one covering the state at this point. and they would either virtually or physically intervene in those cases. Obviously, they wouldn't be able to do every case of somebody ending up in the emergency room with challenging behaviors, but the idea is to move towards a system where that's where something like RAFT in Northern Virginia is available across the Commonwealth. I'm
very familiar with them, and yeah, that's what we're trying to avoid here, is that if an APS worker and an emergency service worker get called to the same client, same case, that they don't get into this debate about dementia is a neurological, not a psychiatric issue, therefore we can't take it. What I've always said about that is it has to be person focused, it has to be centered on serving the client as opposed to the diagnosis. We'll do the diagnosis later. Let's all agree that this person is at risk, is roaming, has cognitive impairments. Let's work together to get them help and not have a debate about who it belongs to. And so many times that's what happens in these situations. So when I saw that, I thought, oh God, we definitely need to do that.
Yeah, and I mean, DARS would be supporting DBHDS in that, with that, if that budget amendment is adopted. Again, at this point, we don't really know what that would look like. So
I'll volunteer a ED to pilot.
Say that again.
Well, we know of an ED that would like to pilot such interventions. So let us know how we can work together in the future when able.
Yeah, thanks, Kim. I will certainly keep that in mind. It may be that it's not a specific ED. It may be that it's a specific team that can intervene in different areas, geographical areas. But again, I'm not sure what the specifics will look like.
Right, getting the teams together and telehealth would be a fantastic way to, instead of a mobile unit, we're all mobile now.
Hey, George, I can give you some information offline. There are within CSBs something called a critical incident team, and they often staff emergency rooms. Riverside Doctors has one, for example, so that when people are brought in and the issue becomes, should they be detained? And there would even be a hearing for a magistrate, there's somebody on site. And they do it in Hampton Newport News as well. But what they don't do, in my opinion, is interact very well with APS. So that would be room for us to move. And so I can talk to you about that offline.
Okay.
Yeah.
Great. Thank you. And then just to follow up with Denise, she put in the chat wondering if there's overlap between the two and what's available on the statewide basis. So Denise, which two is that?
The CIT and the mobile intervention team, I was kind of what the overlap is there, and like what, where the, I'm sure we have regional statewide differences as to what's done. I'd also be curious to see for the training for the CITs, is that a standardized training, or is that something that each region or area comes up with their own training kind of based on? Again, kind of like I would think one of the goals would be kind of like, this is a standard practice statewide, and if you're in Roanoke, that CIT has the same training as it does in Charlottesville, in Norfolk. I'm just kind of wondering like where things are. It seems these things tend to be a little fragmented, and people are kind of doing their own things, and that's kind of my impression on you guys may have a much better idea, but that's sort of where I'm kind of wondering where we are, where that overlap is, and how, what are they actually doing? We have the CIT that's at Doctors Hospital here, but not all hospitals have a CIT.
Yes.
They're not there all day. So
that's true.
again, kind of like where on a statewide level is all of this right now to get that baseline? And what do we want to work towards?
So George, there's a guy, Colonial Behavioral Health, his name is Dean Barker, and he's an expert. He put together the team at Hampton Newport News CSB when I was there, and now he's at Colonial. And to Denise's point, he did the training, he supervised the teams. We can get Dean Barker to help us look at what's already been done.
Would we like to invite him to the next work group meeting?
Sure.
Okay. Yeah, so Denise, I'm not really sure at this point. And again, going forward, it's all speculation at this point in terms of that mobile crisis response team. So yeah, so I know the APS workers they do have a dementia module, but it's very short. That's part of their training. So the idea would be to provide them with a bit more in-depth training on dementia. So again, I think it's up to the regional directors to decide what trainings are made available to their staff. So I've been in conversation with Paige McCleary, who runs the APS program at DARS, about this before, and the difficulty is that we can't actually mandate anything, so it has to be picked up by APS through the Department of Social Services. So we can explore better cooperation in terms of improving their dementia curriculum. Oh, thanks, Rick.
Yes, it looks like we have
So-
plenty thoughts that we can be working on for projects for next year.
Yeah. So, yeah, I agree. The other one that I was thinking of was B2 under the training goal, which was to coordinate dementia-specific outreach through triads and SALT councils. So that's a little bit near and dear to my heart because I'm part of the triad here in Charlottesville, and I think that would be something that we could move forward with fairly easily. I don't think that would be a year-long project. That might be a short-term project. They have their annual conference in Williamsburg, usually in September, October time. So we might want to think about putting together a presentation for that conference as a start for maybe some either virtual presentation that they could then share with local triads, or expanding the Dementia Friends program through triads, things like that. But I think that could be something as maybe a side project if anybody's interested in maybe helping present at that conference. If that's
I'll
something.
volunteer. This is Kim.
Okay, thanks, Kim.
Put my colleagues on the spot.
Kim, I'll help you with it too. You knew I was going to do that.
Well, you're both local, so that makes it a little easier. So I'll explore that, getting us on the agenda at the Triad conference. I know I'm not sure who's running that now, but I'll find out and have some information for you by the next meeting. Yes, but it does sound like we've got plenty of ideas to play with. So I'll try and distill this at our next meeting, which will be hopefully to kind of do the final sign-offs on these primary care toolkits and information, then we can adopt that next project.
George, are you going to send out a meeting Google invite for us to pick the date, or you have a date now?
I don't have a date now. Aiming for May. Do you
Aiming
have
for May,
some
okay.
specific- Yeah. I'll do a doodle poll if that's easiest for everybody.
Yes.
Okay.
Are there other things for the good of the group or the good of our work? Anything would like to ask or add? If not, I think this meeting would be adjourned then. Thank you all very much.
All right. Thank you, Rick. Thanks,
Thank you.
everybody.
Take care.
Bye. Thanks.
Thank you.